Hello, everybody, and welcome to the sessions on the latest bronchiectasis research. I'm Bridget Harris. I live in Scotland and joined the Patient Advisory Group in 2015. Bronchiectasis was diagnosed in 2014, but I coughed for about 20 years before that. But since my diagnosis, I've been really encouraged by the amount of progress that's been made in understanding bronchiectasis and how much is being done to improve patient care. And we'll hear about some of this in the next two sessions and in the following Q&A, when Professor Chalmers is going to speak about the latest bronchiectasis research and Professor Pinnock about digital healthcare and how it might help us. And now over to Mikhail.
Thank you, Bridget. So hello again. My name is Michal Steinberg. I'm a respiratory physician from Haifa, Israel. And I'm delighted to welcome our first speaker for this session, Professor James Chalmers, Head of Respiratory Research in Dundee, Scotland. Professor Chalmers is a pulmonologist and researcher passionate about bronchiectasis. He co-founded Embark, the European Bronchiectasis Clinical and Research Collaboration, and through many successful achievements in the past years. Professor Chalmers leads an innovative research group in Dundee, Scotland, focused on the many aspects of bronchiectasis, as well as many clinical trials which translate the knowledge gained in research to new therapies, making them available to patients. Professor Chalmers will speak today about new therapies in bronchiectasis. So please.
Thank you very much, Bridget and Mikhail, for the introduction. And I'm delighted to be talking about latest research today. My job today really is to get you excited about the science that's emerging in bronchiectasis, and also to give you hope that there are substantially better and new therapies coming for patients with bronchiectasis in the near future. So that's what I hope to do over the next 20 minutes or so. So before we begin, it's important to say that I do a number of clinical trials in the field of bronchiectasis, and I work with charities and with pharmaceutical companies, and I'll talk about some of the work that we do with those partners during the presentation. And also, because I'm talking about research, I'm going to be talking about some therapies that you can't currently get. So it's important to know that these are not treatment recommendations, and you should talk about any questions that you have with your doctor. So having said all of that, let's start talking about where we are today with bronchiectasis research. And the first thing to say is that it's a very exciting time because there's never been more bronchiectasis research. This used to be considered an orphan disease. But if you look here at the number of publications in the National Library of Medicine on bronchiectasis, it's really surged in recent years, heading towards 1,000 publications on bronchiectasis each year very soon, as you can see here on the slide. And Embark, who are the co-sponsors of this conference, started in 2012. And you can see right at the beginning of that wave of increased research into bronchiectasis, which is really exciting. And as Michelle said in the introduction, is really making a difference to how we manage bronchiectasis. And there's more and more people involved in supporting bronchiectasis research. So when we started Embark in 2012, we had only 3 funders, and now we now have partnerships with multiple pharmaceutical companies who are conducting trials in the field of bronchiectasis, and that's important in order to drive forward new innovations. And there's big charities like LifeArc who've recently committed to investing very large amounts of money into new clinical trials for people with bronchiectasis. So this is a really exciting time where people have decided that it's important to invest into bronchiectasis research. And we have great resources now in order to help research into bronchiectasis, including the registry, which Embark runs, which has now over 20,000 patients enrolled globally, and has recently reported results from nearly 17,000 patients in a publication that's been online in the last couple of weeks, and has shown, for example, big differences between countries in Europe in the microbiology of bronchiectasis. In the dark colors are countries where more than half of the positive cultures are Pseudomonas, which is a bacteria that you've heard about already today. And you can see most of the Southern European countries have higher rates of Pseudomonas, whereas the lighter colors at the top are countries where organisms like Haemophilus are more common. And you can see where you live in Europe makes a big difference to the kind of bacteria that you're exposed to and therefore that you're infected with. And that's the sort of data that's coming from these very large databases that are now available for bronchiectasis. So the message here is that there's more research than ever before, there's more investment in research than ever before, and there's resources that allow us to investigate bronchiectasis at a much larger scale. But my challenge today actually was to talk about new treatments and clinical trials. And so in order to do that, I really need to look towards the future. Embark, the registry, started in 2015. And so when I was thinking about how we look towards the future, I remembered that one of my favorite movies, which is Back to the Future, in the second film, the characters go forward in time to 2015 and look ahead to what might have been going on at that time. They find things like hoverboards and new innovations like that. So I'm going to use the time machine and go forward in time 5 years or so and see if I can give you a picture of what I think bronchiectasis research is going to mean and what kind of treatments we're going to have in a few years' time. So we'll be using a little bit of a time machine. But before we do that, we need to think about what problems our research is trying to solve. And to do that, I thought I would illustrate where we are with bronchiectasis treatment at the moment and illustrate that through a case. So here's Eve, who's a 68-year-old lady with severe bronchiectasis diagnosed in 2015, having frequent chest infections and coughing up lots of phlegm. And from the chat, I know that this is also resonates with many of you attending the conference. And she has Pseudomonas in her sputum samples. She takes a steroid inhaler, and she's had 3 courses of antibiotics in the past 12 months for chest infections. She takes an antibiotic through a nebulizer twice a day for the Pseudomonas, and also takes salt water, saline, through a nebulizer to help clear the chest. And she says that it's frustrating. She spends almost an hour twice a day doing her physiotherapy, her antibiotics, and her inhalers. So that is one of the challenges that we need to solve. So what can we do better for this lady? Well, let's break down what the problems are. We have infection. So she has Pseudomonas infection. She has inflammation, and this is a wee cartoon of these inflammatory cells called neutrophils that cause a lot of the problems. And on the right-hand side is the clearance of mucus from the airways, and she has difficulties with clearance of mucus from the airways. So in terms of infection, she says she feels much better when she gets injection antibiotics, but she can't have them often, and the effect doesn't last very long. And that the nebulizer works, but she has to keep taking it every day, and that's a lot of treatment burden for the patient. In terms of inflammation, she's not sure whether the inhaler works or not. And in terms of the mucus, she feels the physio helps to clear the mucus, but it would be really nice if there was a lot less of it. So let's think about that in terms of research. Are there ways in which we could treat infection more effectively? Can we develop better anti-inflammatories? And are there ways that we could help clear mucus or even reduce the amount of mucus? And that's what I'm going to try and answer for you today. And I'm going to start with better ways of treating infection. So in order to think about better ways of treating infection, we need to think about what happens when we take an antibiotic and why antibiotics often make us feel better with bronchiectasis. And so I'm going to talk about a thing called the microbiome that you may well have heard about. And the microbiome is just all the bugs that live in your body. And believe it or not, your body is full of different bugs, most of which are good for you, most of which keep us healthy. And there's only a few bugs that are damaging to us, like Pseudomonas. A few like Pseudomonas make us ill. And so when you have an infection like bronchiectasis, so you have bronchiectasis and you have a bug like Pseudomonas, you have good bugs in your lungs, but the good bugs are outnumbered by the bad ones. And I've illustrated that here in a cartoon where the green is the Pseudomonas and the other colors like the blue and the orange and the yellow are the good bugs. And you can see there's a lot more green than there are of all the other ones. There's only 2 of the other colors, but there's lots of the green. So this is an infection with Pseudomonas. So what happens? You feel unwell, you cough up lots of sputum, we take an antibiotic. What happens when we take an antibiotic? Well, of course, the antibiotic doesn't know that it's only supposed to kill the Pseudomonas. So the antibiotic kills the Pseudomonas, but it also kills some of the good bugs as well. So the overall amount of bugs in the lungs go down, but you can see there's still more Pseudomonas than there are of the other ones because it's knocked everything down. And so when we stop the antibiotic, many of our patients will say they feel good for a couple of weeks, but then the symptoms come back. Why do the symptoms come back? Because there's lots of space in that lung and there's more Pseudomonas than the other ones. And so the Pseudomonas comes back to the same level that it did before. And we can show that in clinical trials where we measure bacterial numbers after an antibiotic. And you get graphs like this, where an antibiotic drops the amount of bacteria, but as soon as you stop the antibiotic, it goes back to the way it was before. That's why you feel better after an antibiotic, but the symptoms get worse again once you stop the antibiotic. And so can we do better? Well, let's look at this in another way. What would be our dream approach if we think about this in terms of a microbiome? It would be to have some kind of medication that could take out the green ones without taking out the good bacteria, that would stop the bad one in its tracks, but wouldn't damage the surrounding bugs. So that's what I've illustrated here, taking out the green ones. So a targeted treatment. But antibiotics don't do that. So antibiotics will always have a broad spectrum, meaning they'll kill lots of different bugs. So are there other ways in which you could target bugs that are not antibiotics? Well, one way, and this is the advantage of that, is if you manage to take away the bad bugs, you create space for the good bugs to grow back, and you may actually be able to restore more of the normal microbiome. And that's ultimately what we want, is to restore as much of normality as possible. So our bodies already have a clever way of targeting just one individual bacteria, and they're called antibodies. So when your body makes an antibody against a bacteria or a virus, it only makes it against one specific target because your immune system wants to be very targeted in the way that it challenges things. And antibodies are really great. Antibodies bind to bugs and they either kill them directly or they enhance the immune response against the bug to clear it out of the body. And you see that with vaccines like the COVID vaccine that's been so effective in stopping COVID in its tracks. But believe it or not, you can also make antibodies and inject them into patients as a therapeutic treatment. And you might think that this is only theoretical, but we already do this for conditions like severe asthma, where they can be used to stop the immune response in its tracks. And we've used it in COVID, where anti-COVID antibodies were used as a treatment for people with immune problems to prevent them from becoming ill. So this is already something that's used in clinical practice. Could we do this for bacteria? Well, here's an example of how it works. You make an antibody against a bacteria. The antibodies go into the body, they swarm, they bind onto the bacteria, and they help it to kill the bug. And so some of the recent research that we've been doing with an antibody against Pseudomonas is that we took samples from people with bronchiectasis. We isolated the cells that are involved in killing bacteria, which are called neutrophils. We gave them the antibody and we gave them Pseudomonas, which is or we gave the bugs, gave the cells Pseudomonas. We didn't give the patient Pseudomonas. The patients already had Pseudomonas and can have, so we have the bugs, we have the antibodies, and we have the immune cells. Can the antibody help them to kill the Pseudomonas? Well, this is how they do it. So this is one of the cells gobbling up a bacteria, and inside the cell, they then kill the bug. And we can see that under the microscope and we can measure it. And so on the right-hand side, you see a graph where with the control, there's no change in how much they're able to eat the bacteria. When you add the antibody, you get a more than 20% increase in the eating of the bacteria, which is what was illustrated on the left-hand side. And for the killing of the bug, it's increased by more than 30%. So the antibody allows the cells from people with bronchiectasis to kill the bacteria and to clear the Pseudomonas in the experiment. So that's really exciting. It's a potential new treatment for bacteria that's completely specific just to the one bug, which is Pseudomonas. And so this is now going to be tested in a randomized clinical trial, giving injections of this antibody to people with bronchiectasis who volunteer every month. for 3 months to see whether it can either reduce or even eliminate Pseudomonas from the sputum. I don't have to tell you the advantage of this. Rather than taking an antibiotic every day or twice a day or having regular injections, this is a once-a-month injection that would last for the entire month, and so far less burden for the patient. And as we've seen, potentially a different way of challenging the bugs. Are there other ways in which we could target Pseudomonas specifically? Well, another one that's gaining a lot of attention is called phage therapy, which you may have heard of before. But what is a phage? So a phage is actually a virus that naturally kills bacteria. So this on the right-hand side is a phage. That's what it looks like. And it has a bit of DNA in its head. It binds to the bug, sits on it, as you can see, and injects the DNA into the bacteria. And that actually takes over the bacteria and kills the bacteria. And the attraction of this is that the phages only attack one type of bacteria. So they only attack things like Pseudomonas, and they don't harm human cells. So they're a type of treatment that's specific, just like an antibody, and potentially very safe. So again, is this something that might become an effective treatment for bronchiectasis? Well, there are already case reports where people have given phages to people with severe infections. At the top here, lung transplant recipients, people with NTM, and on the right-hand side, Pseudomonas in people with CF. And it does seem to be effective in these individual cases. And so this is also something that's now being tested in trials in bronchiectasis. And this is from the trials registry online, showing that there's a trial in people with bronchiectasis currently recruiting that started in November last year. So I've given you there 2 examples of potentially new treatments that could either replace or become additions to our antibiotic armamentarium that would help us to clear infections. And I think that's really, really exciting. So can we do better around infection? I think we can, and I think that there's some really exciting clinical trials going on that could hopefully lead us to new antibiotic therapies. But bronchiectasis is an inflammatory disease, and the big problem for many of our patients is producing lots of phlegm, which is produced by inflammation. And so do we have better ways also of treating the inflammation in the lungs? Well, the inflammation in the lungs is caused by these little cells, which I've shown here in blue, called neutrophils. And what they do is they go from the bloodstream into the lungs when there's infection or damage, illustrated by the black dots here, which are bacteria. And when they go into the lungs, rather than clearing the bugs the way they're supposed to, which I showed you earlier, they explode, producing these sticky webs of DNA. And that's what gets coughed up, these green webs of mucus and DNA that are sticky, hard to clear. And so it's the inflammation that predominantly causes those symptoms. And the inhalers that we give generally don't help with these types of cells. They help with other things, but they don't target this particular type of inflammation. And so we really urgently need some medications, some treatments that can help to reduce these things. And so one of the biggest and most important developments of the last couple of years has been the development of drugs that can directly inhibit this process by directly reducing inflammation that are not antibiotics. And the new class of drugs that does this are called dipeptidyl peptidase 1 inhibitors, or cathepsin C inhibitors, long names, but they're tablet anti-inflammatories. And in trials, this was the first trial in patients of this type of treatment, a trial of 256 patients all over the world. What's measured here is inflammation in the lungs. And you can see in the blue and the green, which are the 2 doses of the medication, the lines go down after 2 weeks, very low after 4 weeks, and sustained for 6 months. So these are very effective at reducing inflammation in the lungs. And that translated into fewer patients having chest infections. So this is the percentage of patients having chest infections, around 50% in the placebo group over 6 months, and far fewer in the group that got the active treatments. So this is really exciting because it's the first time that we can demonstrate a treatment that isn't an antibiotic can reduce infections. And we all want to reduce the amount of antibiotics that are being used worldwide. And because of the success of this, there's now many more of these drugs being developed, and there's in fact 3 trials of different drugs in this class being tested now in bronchiectasis. And so this is, we hope, something that's going to be available very soon, provided those trials are positive and show benefits similar to the ones that were seen in this phase 2 study. So really, we've got new antibiotic options, and we've got new anti-inflammatories that can reduce the inflammation in the lungs and provide benefits. And so you'll have seen already today this image of the vicious cycle of bronchiectasis. There are various versions of this that say that there's inflammation in the lungs, there's infection, there's damage to the lungs, and there's difficulty clearing mucus. And this is always talked about in terms of the disease getting worse. And what I think is really exciting is that we've now got really promising potential treatments that can improve things, meaning we can actually reduce inflammation directly. And when you reduce inflammation, our research now shows that that can also reduce the risk of infections, that you also see improvements in mucus clearance when you reduce inflammation, because inflammation is the major driver of increased mucus. And so potentially you can end up with a virtuous cycle rather than a vicious cycle, whereby giving better treatments alongside physiotherapy and exercise and the things that we've talked about today, reducing inflammation may also reduce the other aspects of this cycle, setting up a beneficial cycle that will result in patients' symptoms getting better and better. That's the hope, and that's what we're really aiming for with these new treatments. So the last thing on my list was mucus and trying to improve the clearance of mucus from the lungs. So what are the latest developments in the clearance of mucus? Well, firstly, the anti-inflammatories are expected to have an effect on mucus because inflammation is the main driver of mucus production. But the other thing that happens when you get too much mucus is this normal healthy airway, which has a few glands that make mucus, which are illustrated here. They make more glands, which make more mucus, and they make the wrong type of mucus. And that's what our research has now shown, is that you need a little bit of mucus to keep the airways clear, and even healthy people produce about a Coca-Cola can of mucus a day. But using measurements on samples, we can show that what happens in severe bronchiectasis is you make too much of a bad mucus, which is a pro-inflammatory mucus. And you also get sticky DNA from these inflammatory cells, and together they make this difficult to clear mucus that's very dry and very sticky and very hard to bring up. And so by understanding that, and also the fact that you lose the hairs that clear the mucus from the airways, by understanding what goes wrong in this system, you can start to develop treatments that target those things. And there are now specific treatments being developed to reduce the amount of mucus being produced, to reduce the amount of DNA coming out of these cells. So imagine in the future a treatment that doesn't just help you to bring up the mucus, but actually reduces the amount of mucus being produced by these glands, and therefore actually resolves the problem that is causing all of the symptoms. And there is some evidence that you can get back to normality. So this is a study where we took samples from people with bronchiectasis. These are the videos of the cilia which clear mucus from the airways. And when you compare healthy people, this is the ability of the samples to beat. Bronchiectasis patients, not surprisingly, have lower ability to clear mucus, the beating amplitude of the cilia. But when you treat them, when you grow them in conditions where you've taken away the inflammatory stimulus, the vast majority of patients can go back to a normal level. And that's, I think, a wonderful, hopeful message to say that with the right kind of treatments, it is going to be possible to restore normal mucociliary clearance in most people with bronchiectasis. And that's really what we're hoping for. So I hope I've given you real hope around infection, real hope around anti-inflammatory treatments, and also real hope that the next generation of treatments may also be able to restore normal function to the airways. So we are going back to the future. Let's jump in our time machine and say in 5 years' time, what are the treatments going to be like for bronchiectasis? Well, I hope that in addition to the kind of antibiotics that we use at the moment, maybe for infection, instead of taking treatments every day or intermittently, there may be monthly injections of antibodies or other types of targeted treatments like phage that could treat infections more effectively. For inflammation, let's hope there's daily anti-inflammatory tablets that are effective against this specific type of inflammation that causes the problem in bronchiectasis, and that there's specific treatments alongside physiotherapy that also reduce the amount of mucus that is produced and restore things to a normal balance. And I think this isn't just fantasy. I think that the research that's going on gives us a very realistic chance of having some or all of these things within the next several years. So I've got a couple of minutes left, and I want to talk about one final thing that is going to make a revolution in our healthcare, I think, and that's artificial intelligence. So for those who haven't experienced artificial intelligence, this is the idea of computers that can think, essentially. So computers that can solve problems and can help to support healthcare. And this isn't something that we're using much in the NHS at the moment, but there are now online apps like ChatGPT, which some of you may have already read about because it's been in the newspapers a lot, which are open artificial intelligence, where you can go on and you can actually discuss with an artificial intelligence computer questions, ideas. You can ask it to do things for you, and it will. And it's really quite astounding and gives an indication of how artificial intelligence may be able to support healthcare. So for the final couple of minutes, I went into ChatGPT and I asked the artificial intelligence how you should manage bronchiectasis. And quite impressively, this is what it told me. So it told me that bronchiectasis is a chronic respiratory condition caused by damaged and widened airways. So we've heard that today. It told us that in terms of medication, the doctor may prescribe antibiotics or inhalers, that we should do airway clearance and lifestyle modification like quitting smoking, avoiding environmental irritants, and it later on talks about diet. So it actually gave pretty good medical advice as an artificial intelligence for how to manage bronchiectasis. So having seen that it did such a good job with this, I went and I asked it to write my talk for me and say, what do you think should be the future treatments of bronchiectasis? And again, it did a really good job. So the artificial intelligence said anti-inflammatory drugs, which we've talked about today, talked about gene therapies because it was thinking about cystic fibrosis, alternatives to antibiotics, and it specifically mentioned phages, and novel airway clearance techniques. So it turns out you didn't need me to give this talk today. The artificial intelligence could have done it almost as well. So having seen it was so good at that, I thought I have to have a bit of fun with this. So I then asked it, tell me about new treatments for bronchiectasis. But I thought I'd do it. One of my great loves is Bruce Springsteen. So I said, tell me about new treatments for bronchiectasis in the style of a Bruce Springsteen song. And believe it or not, the artificial intelligence can do that as well. So it's written a song about bronchiectasis, which I couldn't believe. I'm not going to sing, don't worry, because I know I wouldn't be invited back. But I am going to read you the last two lines of the song because I think they make a really useful point. So the chorus at the bottom of this is bronchiectasis, it's a tough fight, trying to breathe with all your might, but we'll keep on fighting day and night for a chance to live and make things right. And then the last one, we'll raise our voices and make some noise. For those who suffer, we'll be their voice. We'll find a cure and we won't rest until bronchiectasis is put to rest. And I can't think of a better conclusion to this talk than to say that we will continue to be your voice, and we will continue not to rest until we find a cure for bronchiectasis. So with that, the crazy scientist will happily take your questions after the next talk. Thank you.
Wow, thank you, James. That was really inspiring, and I see all of these hearts and thumbs up and clapping emojis. So really very inspiring talks. And we'll have some Q&As. I've written down some of the questions in the chat. So we'll move on. Bridget, would you like to introduce the next speaker?
Thank you. Yes. For the next session, we're fortunate to have Hilary Pinnock speaking to us. She is Professor of Primary Care Respiratory Medicine at the University of Edinburgh. She's also involved in the Asthma UK Centre for Applied Research and the National Institute for Health and Research Unit on Respiratory Health and the Allergy and Respiratory Research Group. And Professor Pinnock is going to talk about digital healthcare and how it might help us living with bronchiectasis.
Thank you very much. I'll just share my screen and hopefully you can hear me, and we'll start a presentation. I don't think I can beat artificial intelligence and songs. I'm certainly not going to sing. The introduction's already been done. I'm a family physician by background, but I have a particular interest in respiratory disease and have for many years asthma and COPD. I've also developed an interest in telehealth and digital health, so it's that I've been asked to discuss with you. I've put up a conflicts of interest disclosure. Basically, I have no conflicts of interest that relate to this presentation. I do occasionally do non-promotional talks for pharmaceutical companies, but I'm not talking about any particular drug or indeed any particular device.
Hilary, I'm not seeing if we're seeing your display properly. If you press the top left button, swap display on your screen.
Okay.
There we go. That's perfect. Yeah.
Well, it isn't, because now I've lost everything on my screen. Hang on. It's on the wrong. All right. But what I can't do is make it work. Oh, yes, I can.
Oh, yes,
it's moving on there now. I've
Perfect.
got all sorts of things all over it. Let me just sort my technology out. I'll lose that. Okay, I had a look at the aims and objectives of the Embark project, and I could see the breadth of it. And you know, you've heard from James about some of the pharmaceutical sort of approaches, and but what I've been asked to do is to look at digital approaches, which is very broad and in fact could contribute to many, if not all, of these various fundamental questions that are highlighted. But I'm going to focus on clinical management. Sorry, for some reason it doesn't want to. That's it. I'm going to focus on telemonitoring, perhaps the thing that we think of first when we talk about digital health, and I had a couple of questions that were put to me to answer about telemonitoring. I also want to touch on artificial intelligence, but in nothing like such a impressive way as you, James. And then I want to talk a bit about how we might look forward to a connected digital world of respiratory care, with a few caveats. So telemonitoring, probably one of the most familiar things that we think about when you talk about digital health is telemonitoring. And I think there's basically three different ways in which telemonitoring might be used. One is around a short-term use to perhaps avoid an admission in an acute situation. You might want to prevent an admission, and you might have 10 days, 2 weeks, a little bit longer maybe, of persistent monitoring from a specialist team to allow for an early discharge or to avoid an admission. And we've seen a lot of that going on in the COVID pandemic, where people who were at risk when they caught COVID were given oximeters and were monitored with digital health in order to hopefully watch them through the infection, but potentially intervene where required. So that's a short-term use, and I think there's a lot of evidence for that has been really helpful, particularly emerging from the COVID pandemic. It's also useful for remote consulting and handing on information, and yes, that is me sitting in my practice with doing some remote consultation. and having information about the patient, because I can't examine them, but having that information digitally is a really useful approach. So that's another use for monitoring. But the one I want to focus on is around managing and monitoring stable disease, typically with the aim of reducing attacks and providing early treatment that can improve outcomes. So I couldn't find anything very specific in bronchiectasis that helped me, but there's been a lot of work done in COPD, a condition that often overlaps. So I thought you might find this helpful, and this could inform our thinking in bronchiectasis. This is a trial that I did or led with colleagues in Edinburgh about 10 years ago now. And we divided the participants in the trial into two groups. One group were telemonitored, this is the gadget that they used, and the other group had usual care provided by the same team, respiratory team. So they had exactly the same clinical support, but one group had telemonitoring and the other group had usual care. And one of our outcomes was COPD admissions. This graph shows the number of patients who still hadn't had an attack over the course of the year of follow-up. Basically, the two lines in the two groups are the same. The message is very simple. Home monitoring of COPD did not reduce admissions, and neither did it have any effect on quality of life, breathlessness, anxiety, depression, indeed any of the outcomes that we looked at. What it did do, however, was it generated nearly 2,500 alerts. That's for 128 patients over a year, when a quick calculation suggests that that means, on average, every patient was contacted by a healthcare professional. This is one of the physiotherapists who was working in the trial with us and providing the clinical care. They were contacting patients, each patient, approximately every 2 weeks. That, of course, is unsustainable in terms of a healthcare system, though I have to say the patients absolutely loved it. They'd never felt so well looked after in all their life, which I guess is probably true. But it made no actual difference when we counted the admissions. And we're not the only ones to have found that. There is now a systematic review. The Cochrane Library produces systematic reviews where they look at all the evidence and synthesize the evidence for us. They looked at all the evidence for telemonitoring in COPD, and they looked at many outcomes. This particular plot looks at the outcomes for COPD admissions. You can see our trial is included in that. Now, this is a forest plot, and if you're not familiar with these, I'll give you a very quick understanding of how it works. Basically, you've got 3 different trials, and the outcomes of those are illustrated by the green squares, and then the summary, when their results are combined, is in the black diamond at the bottom. Now, if those results, that black diamond is in the middle, on that middle central line, it means there was no effect. If they had been on the left-hand side, that means that telemonitoring would have been better, and if it had been on the right-hand side, it means that usual care would have been better. And basically, for this, and indeed the other outcomes which they looked at, there was no effect of the telemonitoring. It did not improve any of the outcomes. And that was then the conclusion of this review. Home monitoring of COPD is no better than usual care, though they pointed out that there was no evidence it did any harm, which means, of course, that there may be advantages in monitoring, perhaps for somebody who's particularly concerned and needs the support, or is perhaps remote to healthcare services, or perhaps just prefers that approach. There may be some advantages in it, but it's not actually improving clinical outcomes. So why doesn't telemonitoring work in COPD? And I think this is an important question, because if we want to translate this into bronchiectasis or other conditions, we need to get to the reason why it doesn't work. Well, telemonitoring in a stable situation, trying to prevent attacks, assumes that there are signs that can be detected before the attack starts. That's really important. And that allows you to have time to start an effective treatment, and that effective treatment will actually prevent hospital admission or a more severe attack. That's the assumption that we're making when we use telemonitoring. But that doesn't always work. The measurements might, for example, change too late. Let me give you an example. This, again, in COPD, combines, there's a score which combines the results from the oximeter, heart rate and oxygen saturations, and the green line includes peak flow as well. What you can see, the line with the red arrow is the point at which the attack was diagnosed and treated. And what you can see is that that score quite clearly does go up during the course of this attack. So it looks promising, except that we're not looking at changes that have happened once the attack has happened. That's too late. We need to know a few days before. Now, if I grey out those, it's really a lot less clear. Even a day before, 2 days before, it's not clear at all that the attack was going to happen. So it's not really helping early treatment. Now, there is a condition, this is heart failure, where telemonitoring seems to be more effective. And the reason for that is that there is something that can be measured that does give a prediction. This is weight, because as people with heart failure get worse, they hold on to fluid and their weight goes up. Just look at this. The attack in this graph is at the end where I've done the red arrow. And you can see the people who are having an attack are in the grey diamonds. The people who didn't have an attack are in the circles. Now, if you look back, these are days along the bottom. If you look back a month, 28 days, you could see that even there, before that, there was very little difference between the two groups. There was beginning, a month before, to be a difference. If you go 2 weeks before, that difference is widening, and a week before, it's pretty obvious what's happening. So now there's at least a week, if not 2 weeks, when you can do something to prevent the attack happening. That's very different to the picture we got in COPD with oximetry. What about respiratory rate? And we looked at this, we actually looked at this the other way around. We collected people who were having an attack and watched to see how their respiratory rate got better. That little picture, which looks like a tea bag, is actually a respiratory rate monitor that you can stick to the chest wall. And that's how we got these readings. And overall, yes, there's no doubt, if you look at that graph from the time of the attack at the beginning, the respiratory rate goes down. But actually, the problem is that it's not true of everybody. It's a very variable finding. One patient here, for example, brilliant, clearly changed dramatically as they got better, and potentially, therefore, might be able to pick up and detect a change ready in advance of the next attack. But for other patients, it really didn't work at all. So there may be variability. It may not work for everyone, is an important message. What about sputum colour? This has been suggested. This is bronchiectasis. This is a sputum colour chart. And we know that it does correlate with infection, and James has showed us some of the reasons why that happens. But whether that's going to enable us to predict attacks, it happens once the attack has started. It may help determine whether antibiotics are needed, but it's not predicting them. And I've been looking at the chat and hearing how for many of you, this is actually an ongoing problem. The sputum doesn't clear, or only for a very little while. So actually, is this going to work for everybody? It might work for some, but it's unlikely to work for everybody. So what about the future? I've talked about 3 monitors. I think there will be many more monitors coming up. What about activity levels? How much activity you feel like doing? And I did see a couple of chats about fatigue being an important problem. So, you know, the person who normally goes to play bowls might decide that they don't feel like it this week. Is that a sign that they're deteriorating, that they might be going to have an attack? Maybe wearing a Fitbit or an activity monitor would be helpful. Certainly as a GP, as a family physician, I get called out to see people who are, the story isn't that their chest is worse, but they're just not so well. Very much vaguer than that. What about cough monitors? I've been hearing a lot about cough, and we can monitor cough. Coughs change, how purulent they are. Maybe we can pick up changes in coughing that would illustrate, and maybe that would give us some prediction that things are about to get worse. What about virtual assistants that apparently we can have in our homes and talk to? Could they pick up a change in how we're speaking? Perhaps our breathlessness? Could they pick up something about our throat and how we're talking? Possible. I don't think anybody's looked into that in any detail, but these are possibilities. I was asked about markers within the sputum, within the saliva in this particular illustration, and there is certainly research into this as to whether something of this sort might be able to give us a clue, but there's certainly nothing available for us at the moment. So I think the future does hold some novel things. I think actually the future is going to come to the artificial intelligence, and I think James and I are going to agree on that, perhaps for slightly different reasons. Going back to my study where I pointed out all those false alarms, and 2,500 alarms in the intervention group, in the telehealth group, when we gave our data to machine learners, to people who can actually interrogate that data, they were able to halve the false positive rate by using machine learning and being more specific. So they were twice as effective as the algorithm that we as clinicians had provided. I think we're going to be using artificial intelligence to look at the data that from different people and recognize that people are all different, which means that everybody might need their own algorithm. And artificial intelligence has the capacity potentially to actually personalize the algorithms to say, in this person, given the pollen count or the air temperature, given what's happening in the cough, in the anything like choosing oximetry, in this person, this is going to make a difference, and this is the alert that we're going to give this person. So I think this is coming. I don't think we're there yet, but I do think this is coming. But I think the question that arises, are we ready to trust AI? And I saw some of the comments in the chat about being very careful what you ask artificial intelligence to tell you. It can be wrong. So I'm not sure we're yet ready to trust it, either as patients or as clinicians, but it is coming. I just wanted to touch very, very briefly on pulmonary rehabilitation and telerehabilitation, which can follow several models, either a video conferencing to satellite groups or potentially to individuals, and we know that that can be effectively delivered certainly in chronic respiratory disease, mostly COPD in the studies, but nevertheless there's no safety issues have been identified, and I think we'll hear more about that. Adherence is another factor. Here's a forest plot from another Cochrane review in asthma, digital support for adherence in asthma. It's a bit of a complicated one, but if you remember that on this occasion, the usual care is on the left, and where the diamonds are on the right, that's the smart inhalers or the telemonitoring, the digital support. An impressive improvement in adherence in the studies that used smart inhalers, 23% improvement in adherence. That's really impressive. 12% with text messaging, no difference with web-based programs, but there were only 2 studies and one was very small study, so watch this space on that one. And automated telephone calls had an effect as well. So there is potential here for supporting and improving adherence. So finally, how are we going to implement digital respiratory care? There's a lot out there. At the moment, these tend to all be standalone. And so for the patient sitting in the middle who might want to monitor pollen, who might want to monitor activity, who might want to look at some of the lifestyle changes, they've got however many apps on their phone, they're not connected. They're all, depending on which company, which technology company has produced them, they're all separate. And that's a problem for the patient, but it's also a problem for the healthcare professional who wants it to integrate with their systems and doesn't want to be looking at half a dozen different websites to pick up the data. So that is our current situation. Where we need to go is to connect these up so that they interact through one portal, through one system, through one app. And then the patient can individualize it. As an individual, you as people living with bronchiectasis could decide, I want to know about the weather, I want to know about pollution, I've got a smart inhaler, but I don't want to know, my mood is fine, I don't want to know that, and I'm not a smoker, so I don't need that. And you can personalize your connected system. But that's challenging. It's going to take a while before we get there, many years, many decades. But there are challenges. what is the impact of remote care? When you think about a consultation, I've taken 3 pictures from the world of art. What they share is that the doctor in these cases is taking a pulse. It's the laying on of hand, it's the touch, it's the personal interaction. What does remote care do to that? As one clinician said, you can't offer a tissue in a remote consultation. And there is something here about the effect it has on the patient-clinician relationship, which I don't think we understand yet, and I think we need to investigate more before we go down this line of remote care too far. Positives and negatives, and do come back to me in the chat on some of the positives and negatives that you think of. We also need to think about avoiding digital inequities. The WHO see this as a way of providing universal healthcare coverage, and to some extent that's true. If you're living remotely, digital health could be really, really important, but there are also challenges. Studies are mostly in high-income countries and may not apply to other contexts. And indeed, in many contexts, there is one mobile for a family. And it's usually the young male who's out of work who's using it, and the rest of the family have no access. Elderly are always held up as a group that may have no access or find it difficult to manage telehealth. But if you design it for them, it's possible. Many of the people in our trial were older people, and the very, very simple, basic programming enabled them to use it perfectly okay. And digital by default policies, if you have to use digital, you have no other option. You're going to leave people behind from deprived or communities where they can't use or access digital health. So to sum that up, telemonitoring widely explored in many contexts in order to predict when attacks are going to happen to allow treatment to be stepped in early. And that works if you've got a measure that predicts an attack. But in COPD, and I suggest probably in bronchiectasis, the change may well be too late, too variable, and it may not actually work without producing a lot of false alarms. There is an important future with artificial intelligence, and I think that's going to be the way forward in the not too distant future. And then connected respiratory disease, it's coming, I'm sure it's coming, but I think there will be a long time before we really put that into place as a really connected system. And we do need to think about the challenges of equity and also what it's doing to the patient-clinician relationships. So I hope that's been interesting, and I'm really looking forward to some of the comments that you can put in your chat, because I'd be interested to see what your thoughts are on this. Thank you for listening.
Thank you very much, Hilary. That was really interesting and instructive, and it's encouraging to know that even if artificial intelligence is not quite right yet, that in the future it may have things to offer, particularly with more personalised care. So thank you very much. And now I think Mikhail is going to start the Q&A and give us the first question.
Yeah, so there have been many questions in the chat, and I would like to start with one for Hilary, please. One of the last ones is on the artificial nose, and how often is that tested in respiratory medicine, or artificial nose? That was the question.
I'm not sure quite what you're referring to there. I'm sorry, should I?
I think it's, yeah.
No.
Yeah, I think it's the detecting of volatile acids in the breath.
Oh, okay. Sorry. Yes, there are a lot of them. I did touch on various biomarkers. Yes, I mean, this is the issue, isn't it? Is how often do you have to test anything? It doesn't just apply to biomarkers. It could apply to anything you choose to measure, oxygen saturations or peak flow or symptom scores. And a lot depends on how rapidly the change is going to happen. Now, if you saw that weight in heart failure, if you checked your heart weight once a week, that would be plenty to predict that your heart failure was getting worse. Whereas if you've got something that only changes the day before, you start an attack, you're going to need to check it very, very frequently. So the answer is, how far before an attack occurs are you going to want to, do you need to check in order to predict an attack? We're way off, I think, using these at the moment, that sort of biomarkers in real clinical practice.
Yes.
Thank you very much. There's been a lot of questions about how people find out about trials and if they're eligible. And I thought it might be helpful if you perhaps just gave a brief overview about that, more information on our website. But James, I don't know, could you say something about that?
Yeah, absolutely. So we really want as many people as possible to sign up to do clinical trials if they can. It's a great way to get access to some of the new treatments for bronchiectasis earlier, and also to help to benefit your fellow patients. The best way to do it is to speak to your own doctor about what trials are available in your area. They will either be conducting trials themselves on behalf of other researchers or their own trials, or they may know of nearby hospitals that are conducting trials that you can get involved in. So it's important that you do that, because you should always discuss participation in research with your own doctor, and ideally be referred by your own doctor. But there's so much going on. Most of the people listening here will either be at a hospital that's doing bronchiectasis research or will be near to one. So please do get involved. We love when patients come in and spontaneously say, I would like to take part in research.
Yeah, I can add to that actually. Yes, do make your interest known, whether that's through your hospital, but just letting the research team know if you've got a local university. I mean, we, for example, have people who have said, please do contact us about research. And I know many departments of respiratory medicine will have a list of people who have said, yes, you can contact me, I'd be pleased to hear. There are also some public volunteer sites. The one in Scotland, of course, is called Share, but there are others. And you can sometimes sign up to a website that says, if there's research going on, then you can please contact me. And we sometimes use something like Share to say, please can you find people with asthma who said they'd be interested, or please could you find people with bronchiectasis who said they'll be interested. So there are ways of getting your name on a list.
Thank you very much. And as a patient, I would add that you should really not have any consultation with the doctor where you do not ask, is there any research I would be eligible for?
Yeah. So this is really exciting, and there's been a couple of questions on immune deficiency, which means conditions where your immune system is not overly active but underactive, and specifically one on mannose binding lectin. And James, would you like to refer to immune deficiency in general, and are there or existing or new treatments for these?
Yeah, great. So about 10% of people with bronchiectasis have immune deficiency, meaning the body doesn't make enough antibodies, or the antibodies don't work correctly, or there's another problem with the immune system, and mannose binding lectin deficiency is an example of that. That's usually not significant unless it's combined with other types of immune system problems or things like bronchiectasis. So there are specific treatments. For example, if your body doesn't make antibodies properly, you can get injections of antibody that can replace the dysfunctional antibody, and that can cut infections and prevent further lung damage. And that's usually supervised by an immunologist along with your bronchiectasis specialist. So it's important, we recommend in the guidelines that every bronchiectasis patient is tested for immune system problems as part of the initial workup. A lot of patients will say that they feel that they've got a problem with their immune system, but when the antibody levels and things are measured, they don't find a problem with the immune system. And that's because the problem with the immune system is mostly in the lungs. And I described that in my talk, where the immune system is meant to gobble up these bacteria, but instead of doing so, it tries to contain them by these cells exploding and causing the sticky mucus. So in a way, you could say that most people with bronchiectasis have a problem with their immune system. It's just a different kind of problem. It's that their immune system doesn't cope with bacteria in the way that they should. And so some of the treatments that we're giving now are really trying to persuade the immune system to cope with things in a more normal way. But I think that helps, because a lot of my patients will say, I feel like I've got a problem with my immune system, but the immune tests are normal. I would say most people with bronchiectasis have a problem with their immune response. It's just a different one to the one that we test for.
Thank you. There's been quite a few questions about alternative therapies. Now, I know that's difficult because there isn't much research, but I don't know if either of you would like to say anything about that, things like that.
I can certainly comment on that if you like. I mean, yes, we're often asked about an alternative therapy. You know, shall I try this? Does this work? The answer, of course, is normally I don't know. And that is really very difficult. That's not a yes it does or no it doesn't. It's I just don't know. You've heard James talking about all the trials and things that he's involved with to try and test whether a drug works and all the... I mean, it's a complex process. It takes many years in order to show whether a drug does or does not work, whether it causes harm, whether it has benefits. And that is just not done with most of these alternative medicines. So the answer is don't know. And if you take a drug, okay, there may be risks, but you know what they are. They've been tested and we understand them and we follow them up very carefully and we know what the risks are. If you take a drug that has not been through that process, you have no idea whether it's going to work or whether it's going to do you harm even. So don't know has to be the obvious answer. I don't know what you say, James, to people who ask that question.
Exactly. I say almost exactly the same as you, is that we do a lot of research to be able to say, for example, with your airway clearance, I can tell you that this will probably cut your risk of chest infections by 30% and the risks are X. Or a macrolide tablet, I can say, on average, this will cut your chest infections by 50% and 1 in 100 people will get an important side effect. And we do all of that research so that we can say those things accurately and give you the right advice. Anything that hasn't gone through that process doesn't mean it doesn't work, doesn't mean it does. I just can't tell you. And so I respect anyone's decision if they want to try something, as long as they have all of the information.
Exactly.
Thank you. And coming at it again from a patient perspective, it's very easy to try and grasp at straws, and you read stuff on the internet and you think, oh, maybe that would help, maybe something else would. But the things we know help that patients can do for themselves are the things you've heard about this morning: the chest clearance, the lifestyle, what you eat, the activity you do. Those are the things we really should be concentrating our time on as patients before anything else, because we know they work.
All treatments, and that includes the broad, I'm using treatments in the broadest sense here, all ways of managing any condition, not just drug treatments, should be properly evaluated. The problem arises when these things overlap with nutrition or supplements, what you buy in health food shops. They don't go through that process. So the answer is usually don't know.
Michael, do you have?
And I would like to add that I think something is natural does not mean that it's safe, because usually some of the strongest poisons are natural, so we don't know that, and just being a natural product does not mean that it's safe to use and it's recommended to use. So I think we're out of time, and it's really been 2 wonderful talks, and there's so many questions that are unanswered, but I think you both have offered to try to answer in the chat. So I think we will close the session now, and we'll come back in 45 minutes. So thank you once again to my co-chair and to the two wonderful speakers for their talks.
Thank you. It's an interesting session. Lovely to meet you all.
Thank you very much.